We are live now.
Shall I start?
Yes, ma'am.
साइड सबका डॉक्टर नाम से आ रहा है, प्लीज तो रीनेम करो उनको.
Okay, ma'am. I will rename in back.
Yes, and then start. Babita can start.
तो मतलब ये कोई स्क्रीन शेयरिंग कर रखा है?
Yes, ma'am.
So shall I begin or you?
Okay, ma'am. You can start it.
Okay. Good evening, everyone. A very warm welcome to all our esteemed faculties and our delegates. Today we have gathered for another series of our UA ISOPAB webinar, which is organized by the ISOPAB Gorakhpur and the Prayagraj chapter. Today we have a very important topic, preterm labor and Enigma. Preterm labor is a topic discussed very frequently, and yet when we face it in our day-to-day lives, we feel helpless at times. So it has to be discussed more and more often so that we are very well aware of all the guidelines and all the ways of managing it. So in our series of UA ISOPAB, we have some UA speakers. They give their new views and ideas and the latest guidelines, and we have senior experts with us who act as icing on the cake, and they season it with their experiences over the time. Every auspicious occasion begins with remembering God and Goddess. So today, let us begin our webinar by remembering Ma Saraswati, the Goddess of Knowledge. Please say. May Ma Saraswati, the Goddess of Knowledge, light up the darkness of ignorance with the ray of knowledge. Simultaneously, I request all the faculties to join for the virtual lighting of the lamp. That was indeed a blessing. Now, I would like to invite, it is my honor and my privilege to invite Dr. Sadhna Gupta ma'am, who is the key organizer of all these UA ISOPAB webinar series. Ma'am has been working tirelessly day and night. Kindly put a CV, Tulika. Ma'am has been tirelessly working day and night to arrange these educational series. As we all know, Madam is co-chair Suffolk NCT committee. She's FOXY representative to Suffolk and Vice President FOXY 2016. ICOJ Governing Council member with Best Governing Council Award 21. Corresponding National Editor and Peer Reviewer.
It's okay, Babita, it's okay.
Yes, ma'am. And she's recipient of several awards, organized so many CMEs, workshops, conferences, and has so many publications to her credit. And above all, ma'am is the most deserving FOXY Presidential Candidate 2023. A very warm welcome to you, ma'am.
Thank you, Babita. And in the capacity of President of Gorakhpur chapter of ISOPAB, and concept of the Yuva ISOPAB, because we need the Yuva people in our Indian Society of Perinatology and Reproductive Biology. I welcome each and everyone. And it is our 5th series of Yuva ISOPAB, and all the series has been highly successful, and we have received many new insights, because the young generation always thinks in different way. They have their own challenges, and we have to find solutions to their challenges, and we must have the seniors, mentors to guide the young, and we have to walk together and talk together what our president of ISOPAB, Dr. Gangadhar Sahu, says. So we welcome everyone. I welcome Dr. Gangadhar Sahu, our guest of honor, Dr. Usha Sharma, Dr. Manju Verma, our speaker, Dr. Urvashi Varman, chairpersons, Dr. Ranjana Khanna, a very, very dear friend, Rajesh, and myself and Amrita will be moderating a panel discussion on case situation with the Madhubala, Dr. Geeta, Rita Singh, Chitra, Garima, Ritu, and the Sumiti Saxena. So we are going to have a very good interactive meeting on the intricacies of preterm labor, which is actually India is the biggest contributor to the preterm birth. And we have to do a lot together along with the neonatologist and along with the pediatrician. So it is a great pleasure that we always receive the blessing of President ISOPAR, Dr. Gangadhar Sahu, and he has graced today as a chief guest and as a president of ISOPAR, National ISOPAR. Can I have a CV of Dr. Gangadhar Sahu? So he is president ISOPAR, where we have come a long way under his leadership. He is, I will not say retired. He is a very, very active teacher, professor and HOD, OB-GYN, BSS Medical College, Bodla. He has graced the position of Dean IMS and SUM Hospital, Bhubaneswar, ex-pro Vice Chancellor, SOA Dean to be University, Bhubaneswar. What he says, he is a disciplined learner who never leaves any opportunity to learn, a passionate teacher who never feels taking attendance, a surgeon who pay respect to tissues, an obstetrician who pay respect to 3 or more lives that include obstetrician too, a gynecologist who understands the physiology before pathology, motivational speaker, writer, positive thinker, and overall an ordinary human being surrounded by extraordinary friends and well-wishers. So it is a landmark which Sir has set up for us that we want to be like that. So a warm welcome, Dr. Gangadhar Sahu, and please give your blessings to this program and Yuva ISOPAB as well.
Okay. Thank you, Sadhana Madam, and the members of Gorakhpur ISOPAB chapter, Amrita, the secretary, Babita, one of the conveners, and all other office bearers. So my greetings from ISOPAB and blessings from Lord Jagannath. So at the outset, I can say it is a successful mission as regards this Juba education in ISOPAB society. So thanks Sadhana Madam and her team for initiating this innovative idea and propagating through the young minds how to face the challenges of an obstetrician, true obstetrician and gynecologist faces throughout his or her career. So first thing I want to say that the message is, as in any exigency in obstetrics, preterm labor also included in that, always we need a teamwork. So my message to the young gynecologists and obstetricians is that believe in teamwork. Don't think that I am the best. Think that your team is the best. Once the concept of teamwork comes into play, then any enigma can vanish within minutes. The small example I can give you. While the construction of Ram Setu was going on, a little animal called squirrel was doing something which Sriram noted. Sriram then brought that squirrel, held in both of his hands and said, "What are you doing? I am marking you continuously, tirelessly, you are doing something. I am doing my best to help you to reach your goal or your mission to go to Sri Lanka." So that should be the concept for everybody's mind. It may be the contribution of Hanuman or the contribution of squirrel, but in the long run, that contribution counts. So that is called teamwork. That is number one. That is my message to my young fellows. So every webinar, I give some message, and this is one. Second is, you should not think that you are above all. There is one X factor that is working. Whenever you are in trouble, where science fails, the spirituality begins. So also in labor room, many such miracles can happen if you believe in God. Therefore, just to quote from Bhagavad Gita, so sarva dharman paritejya mamekam saranang braja aham tang sarvopapebhyo mukkhai mahimasucha. So whenever you are in trouble, you are cornered, there is no other way than pray God, pray Lord Jagannath, oh Lord Jagannath, oh Lord Vishnu, you have saved Draupadi in that Kuru Sabha. So I am in labor room, in dire trouble. Please help me. So that is my message to the Juba. So be always be connected with spirituality. So nobody can define that X factor or know that X factor. Regarding preterm labor, yes, it is enigma, but one should not be panic in while managing such cases or coming across such cases. Follow the guidelines, we will face the least trouble. Thank you very much. Long live Isopar. Long live. Again, I will say, you have to repeat that much pain you have to take. I will say long live, you have to say Isopar 3 times only. Long live.
Superb.
Superb.
Long live.
Superb.
Long live.
Superb.
Oh, thank you very much, Gorakhpur chapter, for inviting me. So wish you all the best, and my special best wishes and blessings from Lord Jagannath for Sadhana Madam to achieve her goal. Thank you very much.
Thank you, sir. Your message and your wishes are precious, and you said so many things in very, very short time. We have to connect science with spirituality, and it is all, we are only a minuscule on this universe, so everyone's contribution matters. So thank you. We really need people like you around us. Thank you for being with us. So Dr. Babita, you introduce Dr. Usha.
So again, it is my honor today to invite and say a few words about Dr. Usha Sharma. Ma'am is President ISOPAB 2020 to 2022. She is consultant obstetrician and gynecologist, Patna KK Memorial Hospital and AK Memorial Nursing Home. Ma'am is honorary consultant, Red Cross Polyclinic, Patna, chairperson of Safe Motherhood Committee. She has delivered many keynote address and scientific deliberations all over India in FOXI, ISOPAB, RCOG, and other societies. She has contributed chapters in FOXI publications and former East Zone Fellow Representative, RCOG. We all know as a very, very pleasant and sweet personality. A very warm welcome to you, ma'am.
Thank you, Babita, for such a nice introduction. A really deliberate one you have done. Now, it gives me immense pleasure to attend today's webinar as guest of honor, as Gorakhpur and Prayagraj ISOPAB chapters have joined hands. Two dynamic leaders, Dr. Sadhana Gupta and Dr. Ranjana Khanna. The chief guest, Dr. Gangadhar Sahu, has done appreciable work in the way of increasing numbers of city chapters and life members. Congratulations, Dr. Gangadhar. Preterm labor poses challenges for obstetrician and neonatologists affecting the pregnancy outcome. Dr. Urvashi Barban Singh will deliberate on prediction and prevention of preterm labor. Case-based panel discussions with very learned Dr. Sadhana Gupta and Dr. Amrita S. Jaipuriyar as moderators, and all the knowledgeable panelists will be giving their insight to deal with the cases for best results in preterm labor. I'm sure all the webinar attendees will benefit from today's program. Thank you for inviting me to such a nice webinar. And you don't have to say anything. Long live ISOPAP. This is my slogan.
Thank you so much, ma'am. And now I would like to invite Secretary of Gorakhpur Ops and Gynae Society, Dr. Aruna Chaparia, to invite respected Dr. Manju Verma, ma'am.
Thank you, Babita. Good evening, all respected faculties. I would take the opportunity to invite guest of honor, Dr. Manju Verma. We all know that ma'am is past president, UP chapter of Ops and Gynae. Her academic credentials are full of medals, 16 gold, 2 silver.
2 lines only. 2 lines
Ma'am,
only is enough.
इतने सारे medals, सोना चांदी कुछ
छोड़
तो
दो,
बोलने
छोड़
दीजिए.
दो, वो पुरानी बात हो गई.
Okay, it's my privilege and honor to invite Dr. Manju Verma. Ma'am, we want your blessings.
Thank you, Dr. Chaparia. And first of all, I would like to extend my heartfelt thanks to the Gorakhpur Society and the Prayagraj Society for honoring me as the guest of honor. And I would definitely like to thank Amrita and Dr. Sadhana, our presidential candidate for FOXY. I think I'm really, really very, very thankful and wish you and pray to God that you succeed. Today's topic, as we all know, the preterm labor and Enigma is very, very significant because it is not only affecting the mortality and morbidity of the neonate, it is going to affect the health and the morbidity, even maybe mortality of the mother. And we all know that it's a global problem with a very, very high incidence of 75%, contributing more than 75% for the neonatal deaths. And therefore, we would like to say that what is being exactly needed is the accurate diagnosis, which is really difficult. To find the risk factors are there. They may assist in diagnosis, but in prediction, it is really, really difficult. And one should, I would like to say that we should always invest, involve the primary, secondary, and tertiary care so that we can tackle the problem of preterm labor. And I would simply like to say that I would not like to stand between you and the speakers, and I would like to thank, I forgot, I should have thanked the national leaders of the ISOPAP, Dr. Gangadhar Sahu and Dr. Usha Sharma. Before saying anything, I think you will forgive me for that. Then I would now like to say that this is a very, very important topic, and today's webinar is going to clarify the problems that one can face and how it should be dealt. Thank you very much.
Thank you, ma'am, for joining us and giving your pearls of wisdom. As our guest of honor, Dr. Manju Verma said, that preterm birth is among the most complex and important challenges in obstetrics, although the causes of preterm labor are not well understood. The burden of preterm birth is clear. These newborns accounts for approximately 3/4 of perinatal mortality and half of long-term neonatal mortality at significant social and economic cost, because preterm is the common endpoint for multiple pathophysiological processes. Now, carrying forward our scientific session, we move forward our first session, preterm labor, prediction and prevention, where we will have a wonderful talk delivered by Dr. Urvashi. And to start the session, I would like to call upon the chairpersons, Dr. Ranjana Khanna ma'am and Dr. Rajesh Gupta. Dr. Rajesh Gupta is a renowned pediatrician of our Gorakhpur city. He is director and consultant pediatrician, Annapurna Child and Maternity Home. Fellow Guide for Dawn Dip, Member State Working Committee, IMA UP, President IMA Gorakhpur Branch, Ex-President Indian Academy of Pediatrics, Gorakhpur Branch, Ex-Secretary IMA Gorakhpur. Welcome, Dr. Rajesh. Now, second person to introduce is a beautiful lady with beautiful smile and with a well organizing skills, which we have recently noticed during Allahabad. Ma'am is National Vice President, Foxy, Founder President, Prayagraj Chapter of ISOPAR, 2021 to 23, ICOG Governing Council Member, 2021 to 23, President, Allahabad Ops and Gynae Society, Honorary Secretary, AOGS 2011 to 2012. Ma'am has been awarded with many national awards, Foxy Dhira Award, Foxy DK Tank Reproductive Health Care Promotion Trophy, Foxy Smriti Myline Award, and she has been felicitated by many organizations, and ma'am has authored many articles and chapters in various books and journals. Now I hand over the virtual stage to our chairpersons.
A very good evening, and it's a pleasure to introduce the speaker of today, that is Dr. Urvashi Burman, and she is a well-known gynecologist of Allahabad. Can I have a CV? Currently, she is Vice President of AOGS, that is our Gynae Society, and she is also the head of the Gynae department in United Medical College. I'm right?
Kindly display her CV.
Yes, ma'am. 1 second, ma'am.
Avinash.
Yeah. So, as I said, she is professor and head department of OB/GYN in the United College. And she's been awarded Best Paper Presentation in UPCOG 2016. She's got several publications. And presently, she is Vice President of our society, AOGS. So, Urvashi, please speak on your topic. We are waiting to hear.
Now I can share my slides. Okay, 1 second. Share slide, I can't see.
ऊपर है, ऊपर, left side.
Ma'am, at first, please open the PPT, ma'am. And then you have to click on share screen.
You downloaded the PPT, Urvashi?
Yes, yes.
Acha, now you will see share slide.
Screen,
वो नीचे
Okay.
green, हाँ, बस हो
Yes,
गया.
ma'am.
Is it okay?
Yes, ma'am.
Yeah, yeah.
First of all, I want to give thanks to Dr. Ranjana Khanna for nice introduction, and good evening to all the dignitaries, chief guests, ISOPAR, the President ISOPAR, and the guest of honor, Dr. Usha, Dr. Manju Verma ma'am, and both chairperson, and especially to all the participants who joined this webinar. And a special thanks to Dr. Sadhana ma'am and Dr. Amrita Jaipuria for giving me this opportunity to speak on this topic. The topic allotted to me is prediction and prevention of preterm labor. This is not full screen, I think. No?
No, ma'am, you can
Okay.
make
So,
it full screen also, ma'am.
As
You can click on slideshow, ma'am. Slideshow, ma'am.
slideshow.
Ma'am, on top you can. Yes,
Yeah.
ma'am.
Yeah,
Perfect.
no, it's all right.
Everybody said that we know that spontaneous preterm birth remains the significant cause of neonatal morbidity and mortality. As Dr. Manju Verma ma'am also said, this is one of the important causes, despite of the intense research and to decrease its prevalence. Preterm labor is defined as the uterine contraction 1 in every 10 minutes
with progressive cervical effacement and cervical dilatation starting spontaneously after the gestation of viability and before 37 weeks of gestation. And threatened preterm labor is the uterine contraction without any cervical changes. As we know, preterm labor could be spontaneous or preterm rupture of membrane or because of other medical causes. The spontaneous preterm labor is the commonest. The incidence is 40 to 45%, and preterm rupture of the membrane, the incidence is 30 to 35%. There are different classification of preterm labor. The most important, what we follow is by the Central for Disease Control and Prevention. As we know, preterm is less than 37 weeks. So between 34 to 36.6 week is late preterm. Before 34 week is early preterm. And before 28 week of gestation is extremely preterm babies. Prodromal symptom and sign of preterm are menstrual-like cramping, mild irregular contraction, low backache, pressure sensation in the vagina or pelvis, vaginal discharge, spotting, or light bleeding. I'm not going into the detail of the pathology because I will discuss detail of prediction and prevention, but I think pathology is, etiology is very important. So I have made only 2 slides. As we know, this maternal or fetal stress activates the maternal fetal hypothalamo-pituitary axis, one cause. Second is the infection and inflammation is the second most important cause of the preterm labor. Third is the decidual hemorrhage. And fourth is the pathological uterine distension, like in multifetal pregnancy, polyhydramnios, or uterine anomaly. These are the main 4 causes of the preterm labor. What happens? In the case of infection, there is release of interleukin and tissue necrotizing factor. In case of maternal or fetal stress, they stimulate the CRH. In case of choriodecidual bleeding, causes release of thrombin. And abnormal presentation in case of multiple pregnancy or polyhydramnios causes release of prostaglandin. All these 4 things causes myometrial activation and cervical tightening, which results in spontaneous preterm labor or spontaneous pre-rupture membrane of the fetal membrane or incompetent cervix. This is in short about the pathogenesis. Now coming to my main topic is predictors of the preterm labor. The predictors are divided into 3 groups: clinical predictor, biophysical predictor, and biochemical predictors. Clinical predictor includes mainly all the risk factor like multiple pregnancy, history of prior preterm birth, presence of genital tract infection, and symptoms of preterm labor. Biophysical predictor are uterine contractions, Bishop score more than or less than equal to 4, and cervical length less than 25 millimeter. Biochemical predictors are fetal fibronectin in the cervicovaginal discharge. Others are interleukin 6-8 and tissue necrotizing factor. And these, which I will tell in detail about PAMG1 and PIGF-BP1. Risk assessment by clinical risk factor is more commonly seen in low socioeconomic status, poor antenatal care, extremes of maternal age, malnutrition. Behavior factor like smoking, alcohol consumption, illicit drug use, heavy physical work. In obstetric history, other risk factors are uterine malformations, previous preterm labor or PROM, previous bone biopsy or cervical surgery. Aspect of this current pregnancy, multifetal pregnancy, genital tract bleeding or infection, short cervix, pregnancy complication like preeclampsia and gestational diabetes mellitus. Diagnosis is done by if the uterine contraction is more than or equal to 4 every 20 minutes or more than or equal to 8 in 60 minutes with cervical changes more than equal to 3 centimeter or cervical length less than 20 millimeter on TBS ultrasound or cervical length between 20 to 30 millimeter with positive fetal fibronectin, then is diagnosed as a case of preterm labor. Out of all, two important predictors are mainly used. One is fetal fibronectin level and other is the ultrasound assessment of the cervical length. So fetal fibronectin, as we know, it is a glycoprotein secreted by the fetal membrane, which helps in the attachment of chorion to decidua. It is like a glue. It beyond 16 to 20 weeks, it is not secreted in the cervicovaginal secretion. If found beyond 20 weeks, it suggests a disruption of the choriodecidual interface and has been identified as the predictor of preterm labor. Its function in intercellular adhesion during implantation and maintenance of placental adherence to uterine decidua. As I said, it works as a glue. Screening of asymptomatic women for the presence of fetal fibronectin at 24 to 26 weeks had a high sensitivity for prediction of preterm labor, and it has a negative predictive value of 99%. It means if the test comes out to be negative, then patient won't go in labor in 7 days. What happens? Mechanical stress causes uterine contraction and cervical changes, which result in choriodecidual disruption and causes release of fetal fibronectin in the cervicovaginal secretion. We take sample from the posterior vaginal fornix or from the ectocervix under aseptic condition with dry speculum before doing PV examination. Sample contaminated with maternal blood and amniotic fluid should be avoided. Fetal fibronectin detection in this cervicovaginal secretion before membrane rupture is the predictor of impending preterm labor. Fetal fibronectin labor are measured by using enzyme-linked immunosorbent assay, and the cutoff we take as 50 nanogram per ml in the cervicovaginal secretion at more than 24 weeks in association with preterm delivery, and presence of fetal fibronectin indicates that the delivery will take place within 7 days. This type of kits are available. They shows like all urine pregnancy tests. This is positive. When 2 lines are present, 1 line is negative and opposite line, this is invalid. In India, what I have seen till now, we are using only this kit. And lab persons are not doing the label, what we used to study in Williams' book, or they are using abroad that 50 nanogram cutoff, this thing. Other biomarkers in prediction of preterm labor are alpha fetoprotein, high serum alpha fetoprotein are associated with preterm birth, preeclampsia, and placental abnormalities. And C-reactive protein, amniotic fluid C-reactive protein, more than 110 nanogram per ml, has sensitivity of 80.8% and specificity of 60.5% is predictor of preterm labor. Interleukins 6 in cervicovaginal fluid detects onset of preterm labor. Beta HCG, high beta HCG in the cervicovaginal fluid found in women of preterm labor. And this phosphorylated insulin-like growth factor binding protein in cervical secretion used to test risk of preterm labor like fetal fibronectin test. Advantage of this PIGF BP1 is that it is not affected by the seminal fluid. But not a single biomarker has been evolved till date, which has sensitivity and reliability for the detection of preterm labor. Coming to the cervical length, this is performed using transvaginal ultrasonography in the high-risk patient between 13 to 24 weeks of gestation. No role of measuring cervical length in first trimester of pregnancy. Routine universal screening is not recommended. Cervical length usually remain constant between 14 to 28 weeks of gestation. Transvaginal ultrasound is the gold standard for measuring the cervical length. We take the cervical length from internal loss to external loss. This picture shows the long cervix. This shows the small cervix. Cervical effacement progresses distally from the internal cervical loss towards the external loss. It is seen on USG before it can be detected on vaginal examination. Different signs, what we used to teach our PGs are, or UGs, T, Y, V, and U. We tell them to remember, try your vaginal ultrasound. And the importance is T, Y, try your vaginal ultrasound. T means when internal and external os both are closed. And then Y, slight dilatation, this is like Y shape. More dilatation, this will be V shape. And when the membranes are bulging, it is ultrasonographically, it is seen as a U. Then, as we know, as the cervical length decreases, the risk of preterm, relative risk of preterm labor increases. And there is very important role of infection also. So if the patient is a high risk case, and so we should, once in a pregnancy, we should always send a culture for urine. Urine culture should be sent in all high risk patient in which there is history of preterm labor or history of second trimester abortion is there. And because genital infection and urinary tract infection are important cause of the preterm labor. Coming to the prevention of preterm labor, prevention is divided into primary, secondary, and tertiary labor. Primary, reducing the high risk factor like infection. Secondary is screening tests for early detection and prophylactic treatment. Tertiary is reducing the perinatal morbidity and mortality after diagnosis, like use of the corticosteroids. There are different measures to reduce the preterm labor. As I told, treatment of asymptomatic bacteriuria is very important. Smoking cessation, maintenance of a normal body mass index, avoiding an interpregnancy interval of less than 6 months and ideally less than 12 months, prevention and reduction of multifetal gestation, no single biomarker performed well as a screening test for predicting a preterm labor in asymptomatic low-risk women. Lab tests in patients with mid-trimester law for risk assessment are rapid plasma resin tests, gonorrhea and chlamydial screening, vaginal pH wet smear WIP test, anticardiolipin antibody test, lupin anticoagulant antibody, activated partial thromboplastin test. For iatrogenic preterm labor, prevention, diagnosis of infection is utmost importance. Now coming to the further prevention, progesterone. Progesterone has a physiological effect on uterine quiescence mediated by a direct effect on intracellular calcium concentration and progesterone synthesis. Two large randomized control studies, PREDICT and STOP IT, showed that there is no reduction in preterm labor with vaginal progesterone in multiple pregnancies. And a recent published randomized control study show vaginal progesterone is effective in prevention of preterm labor in singleton pregnancies. Prophylaxis with progesterone compound. If there is prior spontaneous preterm birth, then we give 70 alpha hydroxyprogesterone caproate or synthetic progesterone 17 alpha hydroxyprogesterone caproate, we give 25 milligram intramuscular weekly from 16 to 20 week of gestation till 36 week of gestation. Or we can give oral or vaginal suppositories, same start from the 16 to 20 week of gestation till 37 week of gestation. Use ACOG said that use of progesterone therapy for prevention of preterm birth in women with singleton pregnancies. Criteria for giving progesterone are history of prior preterm birth, sonographically identified short cervix with no history of prior preterm birth. Cervical shortening less than 25 millimeter, then give progesterone suppository 100 to 200 milligram vaginally from time of diagnosis till 36 week of gestation. In multiple pregnancy and preterm PROM, there is no role of progesterone. This table just I have showed this because this shows the comparison of 70-hydroxyprogesterone caproate with placebo. The p-value has significant role. The 17-hydroxyprogesterone caproate has a definite role in prevention of preterm labor. Aspirin, low-dose aspirin, cyclooxygenase inhibitors has been shown to reduce preterm labor only in women who are high risk for preeclampsia. Smoking cessation, Snee and Brecken, in an analysis of 20 studies, showed that there was a dose-dependent association between a maternal smoking and preterm labor. Coming to the cervical circulars for the prevention, 3 circumstances in which we give cervical and circulars. One is history-based, second is ultrasound finding based, and third is per vaginal finding based. History-based circulage is the circulars. We give circulars as 12 to 14 weeks of gestation in those women with a singleton pregnancy, prior spontaneous preterm birth before 34 weeks of gestation, with cervical length less than 25 millimeter and gestational age less than 24 weeks. Circulars placement should be considered. And progesterone supplementation should be given from 16 weeks of gestation, and injection 17-hydroxyprogesterone caprate weekly or vaginal progesterone daily till 36 weeks of gestation. Ultrasound-based circulars is given in patient with 1 spontaneous preterm birth and cervical length less than 25 millimeter before 24 weeks of gestation in current pregnancy, and supplement with progesterone, same 17-hydroxyprogesterone caprate weekly till 36 weeks of gestation. Per vaginal examination finding based circulars is also called the rescue circulars or the emergency circulars. This is preferably called physical examination based, and this is the circulars is given even after 24 weeks of gestation. This is given when it is diagnosed. Some special situation like singleton pregnancy with short cervix, patient with singleton pregnancy with no history of preterm birth who develop a short cervix are treated only with progesterone. In multiple pregnancy, the body of evidence does not support you try a routine circulars in multiple gestation, but it may be useful in patient with classical history of cervical insufficiency of short cervix. Absolute contraindication of circulars are where procedure is unlikely to reduce the risk of preterm or improve fetal outcome, fetal anomaly incompatible with life, intrauterine infection, patient is in active preterm labor more than 4 centimeter, preterm premature rupture of the membrane, fetal demise, active uterine bleeding. In all these conditions, circulars is contraindicated. There are different types of circulars: McDonald stage, chirurgical stage, worm technique, transabdominal circulars, lash procedure. We are more comfortable and using only McDonald stage. Is how to take this one slide. And other thing which is come in the market is cervical pessary, Arabian pessary. It is a silicone ring which support the cervix in a sonographically short cervix. Sometimes we have to arrest preterm labor for a short duration. Then the goal of treatment is to delay the delivery at least for 48 hours, so that antenatal corticosteroid administration for the maximal fetal or neonatal effect, or to provide time for safe transport to the mother, where facility for NICU or good facility for the preterm baby is there. We want to prolong the pregnancy when conditions such as pyelonephritis or abdominal surgery are present, but unlikely to cause recurrent preterm labor. Treatment can be discontinued after these goals have been achieved. Thank you.
Thank you, Dr. Urvashi. I think it was a very, very nice talk, which you covered in a short span of time. But one or two things I would like to say, that in our practice, I have seen that the role of progesterone is very much there, whatever studies say. And 17-hydroxyprogesterone caproate injection does play a very important role. In fact, initially when I did my PG, so it was all about putting a stitch. You know, we were all very comfortable. I was always very comfortable in putting a McDonald's. But there was one of my patients who had had a string of abortions. I put a stitch in that, and she had her first baby, like child. And after that, in the second pregnancy, I just put her on vaginal progesterone, because by the time the role of vaginal progesterone had come up, and very beautifully she had the second child also. So I think vaginal progesterone is sincerely a very good option. And if you are good at cervical cerclage, and if you're sure it is the best thing to be indicated, then please go ahead with that. Another thing I wanted to point out, you said the interpregnancy interval should not be less than 12 months, but I think better is 18 to 24 months. That is better. So that is preferred. So otherwise, I think preterm labor, we are really dependent on treating the cause and trying to prevent the problem from occurring. I think Dr. Verma wants to say something.
Yeah. I think the thing, as newer things come out, we try to leave the older ones. The stitch in the cervical stitch is supposed to be very, very good, because it is not only, it is physiological. People say it out, but it is physiological because there is a reversal of polarity.
Yes.
Normally, when the uterus contracts, the lower segment relaxes. This is how, if you do it, then the reversal of polarity occurs, and the uterus is going to become quiescent. So this has a basis. This has got a space, space for the prevention of cervical.
But
the PTL and the other thing. Okay,
Anji. But I have not seen a good response in rescue cerclage. I tried once rescue
that is something else.
The membranes were bulging, and heroically, I can, of course, counseled the attendant.
It has now come up. It has now come up as one of the ways of rescuing the patient just for 48 hours. Because once the labor is established, nothing can stop it. The other thing I would like to ask Urvashi to clarify, between how many weeks of pregnancy the fibronectin is predictive?
Ma'am, before 16 week of pregnancy, this is normally present. So usually, so this is between 20 to 24 week of gestation. We should test for.
And after 33 also. After 33 also, if the fibronectin is present, then it is also not to predict.
Okay.
And there is one question. They've asked, what is the role of dihydrogesterone? So I think the role is definitely there. It's got a very good response, and all of us
are that of progesterone. And it is immunomodulator also. Same as that.
I think Ranjana, two things actually. Little bit issues about progesterone. So 17-OHP is the thing which has been like approved. Vaginal progesterone by
time tested.
And
time tested.
Progesterone for the statin labor, and we have to a little bit differentiate for immunomodulation for early pregnancy loss. But for the prevention of labor up to 36 weeks, dihydrogesterone, we don't have that strong.
We are normally using it till 20 weeks. And otherwise 17-hydroxyprogesterone, we are sure we've given it to the patient. And otherwise, we are not sure whether she's actually using the, natural micronized progesterone or not. So it's better if we give 17-hydroxy weekly. So that gives a very good response.
Thank you, Dr. Urvashi.
Congratulations, Urvashi.
Thank you.
Thank you, Dr. Urvashi, for such a wonderful talk. And thank you, our faculties, Dr. Manju ma'am and Dr. Ranjana ma'am, for sharing your experiences with us. Now, for the further proceeding of the session, I call Dr. Babita.
Thank you, Arunaji. So quickly moving towards our session on panel discussion. It is on preterm labor, case-based decision on preterm labor. We have some very interesting cases by a moderator, Dr. Sadhana Gupta, ma'am, as we have told that she is co-chair Suffolk NCT committee, and she is a great academician, 3 times Korean Award winner, 4 times best AICOG research paper. She has authored several chapters in books on varied topics, and she has several publications to her credit, organized many conferences, workshops, CMEs, and recipient of several awards, the important ones being the N.A. Shelja Pandit Award and the Economic Times Award. And our second chairperson, moderator being Dr. Amrita Jaipuriar. She is currently our president of Gorakhpur Obs and Gynae Society. She is secretary of ISOPAP Society Gorakhpur chapter and also secretary of Indian Menopause Society. Overall, she's a great academician, and she's also a recipient of the Best Paper Award in UPCOG. And she has also organized many CMEs, and she has been organizing secretary in conferences. Now, quickly inviting our panelists for this session, we have a galaxy of experts. Dr. Madhubala Sharma ma'am, she is past president of Gorakhpur Obs and Gynae Society and vice president of ISOPAP Gorakhpur branch and vice president also of Menopause Society Gorakhpur branch. She has also conducted many health camps. Then we have Dr. Geeta Gupta, who is director of Shiv Sagar Hospital and former associate professor, BRD Medical College, Gorakhpur. We have Dr. Rita Singh, past scientific secretary, GOGS, and associate professor in Obs and Gynae, BRD Medical College, Gorakhpur. We have Dr. Chitra Pandey, vice president, ISOPAP, Prayagraj chapter, and she is fellow of Indian College of Obs and Gynae and honorary secretary Obs and Gynae of Allahabad Society in 2018. Next, we have Dr. Garima Trivedi. She is executive member, ISOPAP, Prayagraj chapter, a special interest being infertility and high-risk pregnancy. We have Dr. Ritu Sinha, who is secretary of Allahabad Obs and Gynae Society. She's senior consultant, Department of Obs and Gynae, Dwarka Hospital, Prayagraj, and organizing committee member of OBDIL 22, AICOG 20, UPNCon 2018. She has organized many conferences. And editor of Souvenir, UPCon 2018 and SAVMA 2012. And finally, we have Dr. Sumati Saxena, who is vice president, ISOPAP Prayagraj chapter. Her areas of interest being ultrasound, ART, and colposcopy. My very warm welcome to the moderators and the panelists, and we expect a very brainstorming and very interesting session today.
Thank you, Babita, and let me share our screen, and again, a warm welcome to everyone who is today with us on this evening, and myself and Amrita will be going ahead with a very, like Urvashi has already set the stage, a lot of things for the prediction and prevention, and we will go just straight away to case situation so that we know what we really do. So the best teacher in life is experience, and it doesn't matter what you know, what you say, what you believe. It only matters what you do. So welcome to all learned panelists, Madhu, Geeta, Rita, Chitra, Garima, Ritu, and Sumati. We have a very, very long association, and we look forward to a great discussion. So to realize value of 1 year, ask a student who failed a grade. To realize value of 1 month, to ask a mother who gave to premature birth. So it is always remembering. So this ये बच्चा 7वां सा था, ये बच्चा 8वां सा था, ऐसी चीजें हम लोग बोलते हैं. To realize value of 1 week, ask editor of weekly magazine. To realize one value of 1 hour, ask the lovers who are waiting to meet. 1 minute, ask the person who missed the train. And 1 second, who just avoided an accident by a second. And realize value of 1 millisecond, ask the PT Usha who missed her Olympic medal. So it is all about time. That is the preterm labor. So children are the anchors that hold a mother to life. So Amrita, you go ahead with the case situation.
Yes, ma'am. Thank you, Sadha ma'am. The case situation, my respects to our chief guest and guest of honor, Dr. Gangadhar Sahu, Dr. Usha Sharma ma'am, and Dr. Manju Verma ma'am, and regards to the chairpersons and all the panelists and the speaker. So the first case is Mrs. X attended the OPD with complaints of 4 months amenorrhea. Her obstetrical history showed 1 abortion at 5 months, second at 4 months. She had a preterm delivery at 7 months. And at this time, there was clutch given to the patient. On investigation, she's AB positive, sugar is normal, uterus is 16 weeks size, ultrasound shows 16 weeks fetus with good amount of liquor, but her os is open, cervix is 3 centimeters dilated.
Internal also.
Internal os, yes, ma'am. So what is the situation now? And the first question goes to Madhupala Sharma, ma'am.
Yes.
So how will you handle, ma'am? We'll ask madam first, and then we'll take the audience poll. So how will you handle her, ma'am? Will you give her cerclage or follow her up with the progesterone?
I would rather wait because she's only 16 weeks, and even with cerclage, she had a preterm delivery of 7 months. So I would like to keep her on progesterone. First, counsel her whether she would like to go for a cerclage or a bow. And if she's very insistent, then only I'll go for a cerclage in this case.
Ma'am, her internal os is open, 3 centimeters.
Then I could try it, but just we have to go over that. We just have to give it the predictions, like, because
so
even
you will go for the progesterone, na, Madhu?
I would
wish
go
to
for the
give
progesterone. At 16 weeks. At 16 weeks, I would go for progesterone.
Any difference of opinion?
Ma'am, as her internal os is open, I will offer her cerclage along with the vaginal progesterone daily.
Both.
I think, ma'am, cerclage should be preferred abdominally, means at the level of internal os, the Shirodkar or by abdominal route.
We will just, Rita, you have come up with a very, very important issue that abdominal cerclage, that is not that easy decision. So I think we have already, Madhu is for progesterone and Rita for the for cerclage, and Rita is for the abdominal cerclage. So we will say it is a history indicated cerclage. I think we can say, Geeta, that it is a history indicated from your side because she had the mid-trimester abortion, typical history, and ultrasound indicated because she has the short cervix. So Geeta says that you will do the cerclage as well as the progesterone. So everybody is right because every opinion is good, and Madhu also emphasized that she will counsel it, that she is what she wants. So we can give her option also, but it is important that what are the recommendation? I will not actually, we have not taken myself and Amrita for this prediction and prevention part, but if the cervical length is 30 millimeters, so it has not crossed the cutoff. So progesterone is also a fair annum because it is not it has not crossed the thing. And all the recommendations say that cerclage in this patient, it is a history indicated much, not the ultrasound indicated. So the decision of doing cerclage will be the history indicated because it is a very, very strong history and you want to have a double protection also. So it is fair enough. But ultrasound, actually, we say that it is between 30 to 35. You can give it only progesterone. So these are the recommendation actually. So coming to this thing, because Rita has already taken that abdominal cerclage, sometimes now suddenly we are like carried away with so many complicated things. So, Geeta, you opted also for this thing, cerclage. So, what you opt in your practice, McDonald, Shirodkar, abdominal, McDonald. So, any criteria, anybody will like to have, Dr. Aranjana, Manju, हम आपको भी like ना मैडम के लिए, expert के लिए, McDonald is a thing सबके लिए क्योंकि we are not accustomed to it. Yeah, actually we have the different suture technique for the different type of patient. This we want from the panel. Yes, Geeta.
Ma'am, I have done one McDonald in advance. I think the bag was bulging out and patient.
No, that is rescue. That we will discuss. That we will discuss. Bag bulge में तो आप नहीं कर पाएंगे.
Ma'am, I have done one case. I have
अभी
done
रेस्क्यू
one
पे
case and she has.
रेस्क्यू पे हम आएंगे. अभी हम अगर दिस पेशेंट
Ma'am, I am not, ma'am, I am not comfortable with Shirodkar. That's why I am doing McDonald's. And
any difference of opinion? Actually, we have a different set of patient. सुमति आप बताएंगे. सुमति आपका opinion कुछ?
McDonald is the preferred one because it is an easy procedure and less morbidity and morbidity by this procedure. And if it is clearly indicated, it is applied in a clearly indication that the fetus is normal and there is no anomaly and their membranes are intact and there is no infections are ruled out. Before doing McDonald, if infections are ruled out like bacterial vaginosis and asymptomatic bacteriuria, then McDonald is the preferred one. But in case if the vaginal these things are not effective, then you can consider abdominal circulars only.
So let's see. So everybody is doing McDonald, but this is actually a point which we want to give very, very clear message about it. Shirodkar stitch circulars is very good option if you are having the short cervix. So abdominal circulars is very invasive procedure. It is a two-way surgery. You have to do cesarean even if the baby is like very preterm or anomalous. So Shirodkar, we have to master both the technique. So Shirodkar is very useful in women who is having the short cervical length. You have to dissect the bladder, and it is very important that there is a lack of exposure of such a material to vaginal flora. So that as a foreign body, as a infection, and why we are actually like many obstetrical art, actually we are losing this expertise also because it need a bladder dissection. It is a little bit difficult to remove Shirodkar stitch also. So Shirodkar is the thing, and McDonald, when you have got the normal cervical length, it's fine. So the one message to all the audience is this, that when there is a short cervix, we have to retain that technique. It is not that difficult also when we are doing the vaginal surgery and everything. Then just so it is a very good, and the McDonald, any tips and tricks, Geeta and Rita, Sumati, we will say any like a special trick. You all opted for McDonald. So when you put this McDonald stitch, what particular point you want to have in your mind for your tips and tricks for McDonald?
Ma'am, there should be no prick at 12, 6, 3, 9. That is the important point.
12, 6 is
okay. So where you will start if you're not at the 12 o'clock?
Prick should be prick.
Yes.
Yeah, prick.
Any other, yes. So one is because especially at the 3 and 9 position, the uterine vessels are running, so we can have bleeding. Any other point? Because yes.
It should be applied as high as possible where the rugosities are absent. You should just, with the speculum, you should just retract the bladder up, and then you get the smooth area where you should put this point as high as possible, because this patient is already having a history of this thing, previous one abortion, previous one failed ischemic cerclage. That has already been done in this patient in her 3rd pregnancy, and yet she has delivered preterm. So this should be placed as high as possible at the level of internal loss. You should try to put this.
So thank you, Ritu, for bringing it up, because a right insertion technique, and it should be at the cervical, where the smooth muscle of smooth cervix actually meet the rugosity of vagina. That is the point. And another important point is that it should not be into the only, it should be in the cervical stroma, not in the mucosa. So it should have been a fairly deep. And it should not, the stitch also should not be into the endocervical canal. So actually why we put it, because we don't discuss the technique and what is the issue. We say McDonald to sabko aata, it is very easy. But why the stitch is failing? It may be in the not following that good technique, so that we have a very superficial stitch, or we have it, and you have to, like yesterday, 2 days back, we had that you put a cervix, and when you really tie the knot, that you must have this tightening of the feeling that when you tie the knot, it should be closed. So it is very important where to prick, where not to prick. And usually the anterior cervical lip is longer and the posterior cervical lip is shorter. Then you also have to, so big, two good retractor and a very good assistant. It is not that easy actually, McDonald also. In these patients, when you have this thing, cervical problem and many things, you have to have a good assistant also. So it should not be in endocervical canal and it should not be also into the mucosa. So this is a few things about it. So Rita has come up with the abdominal, trans-abdominal circlage. Most of the people, Shirodkar and McDonald, are quite fine. So when you consider trans-abdominal circlage and your concern about it, that how we select the trans-abdominal circlage, that this patient we might think of
only about the indications actually. There are only two indications: when your cervix is unapproachable from the trans-vaginal route, and the second one is the failed trans-vaginal cerclage in the previous pregnancies. If these are the two indications.
Anybody who has done it or find
I've never done this before actually.
So thank you very much, Ritu, for being honest. Actually, why I'm putting this thing, कि जैसे कोई fashion होता है ना, so it is a different sort of dress and suddenly everybody is attracted to it. We don't know it is useful or it is not useful. So it is when the previous, like maybe very, very few cases who have 7, 8, very high number of this mid-trimester abortion, and you feel no space to put an stitch. On those cases you can have and you can do, but the important issue is it is always the two surgeries. You may use a laparoscopically, you may do it.
Sadhana, can I add one indication?
Yes, madam. Yes, madam.
It's definitely indicated if the cervical tears are there and they're extending up till the internal os. Then only the abdominal cerclage is
yes, ma'am. Yes,
that is the only indication in my opinion. Otherwise, I think the vaginal approach is as good as anything else.
Thank you very much, because it is maybe like once in a lifetime you get 1 or 2 patients who need trans-abdominal, but it is not the order of a general clinical practice, and we must understand that it has got it. Even the laparoscopy technique is not that easy. You have to put this thing and it is not that easy. So we have to select the patient, and whenever it is needed, yes, of course, send it to the patient person who is expert in it. So this is the thing, and we have to select the technique according to intravaginal length of cervix. So Shirodkar has given this idea of concept of cervical incompetence to the world, Dr. V.N. Shirodkar, and though no way that where we as an Indian, we don't learn and we don't know how to apply the Shirodkar stitch. So Amrita, you go for the second case, rescue circlage, which is again, it was already on the discussion. Amrita?
Yes, ma'am. So we can very well see in the picture, we can see the back bulging. So a third gravida comes to us with mild discomfort in lower abdomen at 28 weeks of pregnancy with discharge. And while doing a per speculum examination, we see the membrane bulging. The question is to Dr. Rita Singh, what are you going to do now? And any experience you have regarding the rescue cerclage, and what are your tips and tricks?
Ma'am, first, she's gravida 3. Hopefully, her previous 2 deliveries, probably normal vaginal deliveries.
Yeah.
Yeah.
Yes.
So, when the patient comes with this situation, at the same as I do per speculum examination, I will simultaneously take a high vaginal swab culture sensitivity. I will not do digital examination. I will send urine culture sensitivity. I will
this patient has come to you like that. In OPD, she was having a little bit pelvic pressure, and you put per speculum, you see this bag bulging. So really, you will have the time for all the things. Yes, we will go for this thing, but if anybody who will like to wait for urine culture, vaginal swab, or do something, or a little bit frightened that the patient is going to abort in next 1 or 2 hours. So, Garima, are you there? Yes.
Yes, ma'am. According to me, once I have seen this patient in the OPD, I'd like to take her to the OT immediately. And if the fetal heart is there, and I think level 2 ultrasound might be clear, fetal heart is important. And we'll see if the baby is alive. We'll go for rescue circulage, explaining the attendant and counseling them.
What you counsel, क्योंकि you know अभी आपको ये भी डर लगता है, Rita was right, because we are afraid कि जैसे हम लगाएंगे membrane rupture हो जाएगा, ये abort हो जाएगा.
Yes, ma'am. We'll counsel for the abortion. We'll counsel for the delivery at that time only. But we have to take her for the circulage, because that is the only thing we can do to rescue the baby. Otherwise, she'll deliver.
Before circulage, madam told correct that we will do the ultrasonic evaluation of the fetal well-being, fetal weight and growth, and placental position that we should ascertain before taking patient to OT. And while we, when patient shifted to OT, we are preparing for emergency circulage. We should give prophylactic antibiotic to the patient after taking culture sensitivity. And we should inflate the bladder with normal saline, put the patient in the Trendelenburg position, so the fetal head will push up. And yes, we'll have to explain the patient the chances of rupture of membrane at that time. Even post-op complication may be there, so we'll have to patient. But yes, rescue circulage we should do after counseling the patient and doing pre-op investigations.
Yes, Ritu.
Ma'am, actually, when a patient present in such a situation, it's actually we have to individualize the situation depending upon the gestational age. Here, the gestational age is only 28 weeks, and the clinical presentation, whether this patient has contractions or not. So before taking this patient,
that is why, yes. Because yes, wonderful message by Ritu. Yes,
and uterus should be relaxed. There should not be any contraction. And secondly, the dilatation should not be more than 3-4 centimeter. I think it should not be more than 4 centimeter. And the third thing which I want to say is sometimes since she is a multigravida, the cervix sometimes also is very relaxed type. So it could be because just the herniation of sac into the vagina, or it could be just the hourglass appearance of this. And so when you push this back, cervix might not be fully dilated. So you can just put the patient.
There is a formation of bag of membrane.
It's formed.
So the membrane is there. Na? Sometimes it's just the hourglass appearance. This thing. It is just
sometimes
coming.
Multi-patient, they are patulous os.
Yes,
also,
that's what I'm
cervix
saying.
Cervix
Maybe
is 2
the cervix is
centimeter
not
short
dilated
cervix.
because the patient,
But the bag of membrane, they are not bulging.
So two things is coming, Ritu, very, very important point that you see for uterine contraction, because if it is not a plain cervical incompetence, so we have to differentiate in the premature uterine contraction, which is pushing membrane, and we have to differentiate between the thing when there is a simple cervical incompetence. And in those cases, actually, it looks like that it is a 5 centimeter or it is a fully dilated, but it might not be there. It is just a herniation of membrane. And then our techniques like putting the patient in steep triangular position, filling the bladder with the catheter, that will help, and it goes beyond, and then you put the circulage and you put on the progesterone as well. So I am done in like 7 or 8 cases, but only in 2 cases we could continue because they were the right candidate. And one patient was infertile, like endometriosis. She didn't have the second child. So 20 weeks we gave the rescue circulage, same situation. She had a term delivery for the cesarean section. So it is like a obstetrician, जो Dr. Gangadhar साहब ने कहा ना कि we remember God and we try to do our best, because you cannot actually leave this thing. Anyway, patient is going to abort, so do the best thing. And uterine contraction, don't put into the bleeding patient. Don't put into the patient when there is any contraindication, but don't put when the patient is having an active uterine contraction, because otherwise it will go through. So thank you very much for everyone's input. This is important. So coming to this is what facilitates steep head down tilt, a balloon, and filling of urinary bladder and amniocentesis.
I have done one case.
Yes, Geeta.
Ma'am, I have done one case at 30 weeks of gestation. She was priming with the preterm labor. And she was around 3-4 centimeter when she came to me, and membrane was bag was there, and I told her that I cannot do anything because I cannot do a stitch. But she was along with her along with the sister of medical college. She told me that, ma'am, whatever you can do, you do it. Then after taking consent, I have given McDonald stitch, and she has crossed 37 weeks along with the vaginal progesterone.
So
And
these
she
are the
delivered at
success
37 weeks.
stories. Yes, yes, these are the success stories. And let's try our best and leave the thing with that to the God, what we can say. But it is the thing that we should not afraid of. And when the patient is cooperative also. So patient who are very dicey. Yes. So one Chitra, say IVF centers wale, why I put a we have put a very small question that many IVF centers put in all IVF pregnancies are played, and more so in the twins. So your comment, Chitra, whether it should be done or it should not be done. Chitra,
Yes, ma'am. It should not be done, ma'am, as putting encerclage can itself initiate preterm labor or abortion. It can initiate abortion or preterm labor. So it should not be done in all twin pregnancies.
So thank you very much. Actually, this is the thing which we have to discourage in our practice, be it anything. So this is like what Chitra has said. It can initiate the junctional uterine contraction. It can cause the infection as well. So this is the very good Dutch trial which says, and the twin pregnancy is different. What we want to give message that the twin pregnancy have got a different route for the preterm labor. Whatever we do, they have the more susceptibility to go into preterm labor because it is a sheer volume over distension and the other. So the cervical circlage is not effective. Very, very strong RCTs are there that it is not effective. Progesterone might be effective, but it is not that so what is in the singleton pregnancy. So vaginal progesterone, we have now few studies which says that it might be effective in twin pregnancy, but absolutely in twin pregnancy, cervical circlage is not going to prevent the preterm labor. So this is very important message from our panelists. So Amrita, you go for the third case.
Coming to the third case, and this goes to Dr. Garima Trivedi. A second gravida, previous vaginal delivery at 38 weeks, last childbirth 2 years ago. On 18 week scan, the length is 3 centimeters. On 24 week scan done for persistent pain in abdomen, cervical length was found to be shortened 2.8 centimeters. And at 30 weeks, she comes at night with tightness of abdomen and backache. So now how do you confirm whether it is actually a threatened preterm labor, or what would be your first line treatment? What prophylaxis you're going to give? What about steroids? So
thank you.
All these questions are bombarded to you now.
Thank you, ma'am. Ma'am, as she has no previous history of any preterm birth and on screening, her cervical length has...
Garima, जोर से बोलो.
Ma'am, on the basis of history, she has no history of any preterm birth, and on serial scans, her cervical length is pretty good, like more than 2.5 mm all the time. And at 30 weeks, she is coming at only with the complaints of tightness of abdomen and backache. I would like to...
गरिमा, उसको तुम एडमिट करोगी कि घर भेज दोगी? पहले तो ये बताओ. रात में 1 बजे वो आए हैं.
मैं पहले तो देखूंगी और डिसाइड करूंगी कि ये थ्रेटेंड प्रीटर्म लेबर है या एस्टैब्लिश्ड है.
Yes,
first
great.
I have to categorize it कि whether she is like having vague abdominal pain or she is ideally in the definition of threatened.
So you will admit her, na? You will admit her.
Yes,
you will admit her. You will admit her. So
yes,
one point, don't send these patients. Don't send these patients कि अरे कुछ नहीं है, और closed है, कुछ नहीं है, और वो 4 घंटे बाद active labor में आ गई. So so go on, Garima.
It requires time for observation.
Yes, yes. So it is not a one-time diagnosis. Great, Garima, go on.
Yes, ma'am. And then, ma'am, for second question is the diagnosis. I'll do her per speculum examination and we'll try to take the high vaginal swab for seeing any kind of infection, because it might promote preterm labor in these patients. And thirdly, if a patient is having mild uterine contraction on examination, irrespective of the cervical changes, I will give her a tocolytic to cover the steroid, and will give her steroids also, and will give her progesterone, and then we'll observe how she responds to the antibiotics, progesterone, whether the pain subsides or not, ma'am.
And
So one thing-
tocolytic of choice, what tocolytic would you like to give?
Ma'am, nifedipine is a good option in these cases, or we prefer to give nifedipine orally, and then we can monitor her on that before switching over to beta mimetics.
No, ma'am, the baby is 30 weeks. So what comes to your mind? She can end up in labor or deliver within a period.
If there are no cervical changes, so I'll try to arrest that uterine contractions with the help of tocolytics and antibiotics and progesterone, so that I might get the time for the steroid coverage at least.
No, tocolytic of choice.
Ma'am, nifedipine.
So one question we will say to Dr. Manju Verma also, vaginal swab everybody says, but many of us don't do, and actually it is the thing that like we have a lot of discussion, like in many diverse geographical regions, they say actually vaginal swab is not helping us at all. Because we can give antibiotics if the membranes are not intact, if we can give. So vaginal swab culture sensitivity, Madam Dr. Manju Verma, what's your opinion about it in our setting? Like UK does the beta streptococcal screening, but our research from Queen Mary from Delhi and say that it is not helping, and we are not having a streptococcal infection. We are, if it is, then it is a E. coli. So, madam, your comment, क्योंकि सब लोग कहते हैं urine culture is fine, treatment of UTI is fine, but vaginal swab culture sensitivity, how far it is has been found useful? Your comment on it.
I mean, vaginal swab and the cause of preterm labor is bacterial vaginosis. Yeah, you know, if you can diagnose bacterial vaginosis, then it is something different. But otherwise, when you are doing a pulse speculum examination, since patients now come with the Google information, so when you are doing a pulse speculum examination to find out, take a posterior vaginal culture, posterior forex. I think I've never taken it, to be very frank, I'm telling you. And
yes.
I
Thank you very much.
Thank
you very much. Because
the West and the
everybody's
East,
saying,
because they have maximum of facilities, they can do whatever they feel like doing. And here we have to be very, very rational, as well as because of the constraint of you know, economic constraint, it is really difficult. Even when you take a swab, it will going to give information after 48 hours.
Yes.
So
that's why, because it is a teacher's opinion, and Western Fund is not doing any, like everything right also. They are NHS supported. ये करना है तो करना है. But what is our research shows that it is actually not like having.
It's not going to affect the management at the moment when the patient has come.
So steroid, Ritu, Garima, तुमने कहा steroid देंगे. Garima, everybody will give steroid, na? So yes.
Magnesium sulfate in this case, use of
yes, ma'am. That's what I was insisting upon, Dr. Garima. I was asking repeatedly. It's a choice.
Yes,
30 weeks neuroprotection.
Or 30 weeks, na?
Magnesium sulfate we will give only when we are expecting delivery within 24.
If we are expecting delivery within 24, then only we have to give.
She might
deliver.
You never know. But she's not in established labor. It just threatened.
No, her cervix has shortened. Antenatally also she has.
A little bit difference of opinion again. So let us come out with the what we do. क्योंकि Maxel भी full dose में लोग थोड़ा सा घबराते हैं कि so very valid point. Actually, Maxel for neuroprotection is indicated when you think that the delivery is imminent. That is very important. If the patient in 4 or 6 hours she is not progressing at all, and you think that the pain has subsided, you can like omit Maxerp also. So this steroid is good, and it is important that we have to have the gestational age good assessment. क्योंकि steroid के लिए मैं इसलिए बात करूँ कि 24 to 34 week and after 34 to 38 week. Now again few question, क्योंकि though it जैसे इलेक्टिव सिजेरियन करते हैं या 36 वीक करते हैं, नाउ we have only 1 or 2 paper who says that it might cause some babies like behavioral disorder. I don't know that how they like select for it, but the giving of steroid even from 34 to 37 week actually reduces immediate respiratory complications. That everybody agrees, whether it is RCOG, whether it is, but 1 or 2 paper have given question marks. So after 35, 36 week, I think it is better that we counsel the patient that it might help usually, but we want to be that papers also that it is, but I think Dr. Manju Verma is like having some behavioral problem. There are so many co-founding factor, and allocating it to steroid use seems very, very remote idea. So this is important, that steroid is important, and it is course betnisol. Any choice, Chitra, betnisol, dexamethasone, agar dono available hai.
I prefer betnisol, ma'am. I prefer betnisol 12 milligram intramuscular, 2 doses 24 hours apart.
So we also, yes, thank you very much, because betamethasone is considered superior for prevention of RTS in comparison to dexamethasone. And any idea about repeat course? Now this is again gray area. पेशेंट ये सेटल हो गई, आपने स्टेरॉइड का कवरेज दे दिया, अभी वो 30 वीक है ना, तो 32 पे फिर आ गई वो, तो आप उसको 32 पे 33 पे तो फिर से स्टेरॉइड देना चाहेंगे या नहीं, या one dose? What is your practice?
We can give single dose if we are expecting delivery within 7 days.
Yes.
Madhu,
The previous dose has been given 14 days back.
Oh.
Then
so you can previous dose, ma'am, we can repeat. We should repeat if previous dose has been given 7 days. It is since last 7 days,
14
previous
days.
dose,
14 days,
and we are anticipating the delivery imminent within 48 to 72 hours, and patient is still less than 34 weeks.
And it is a full dose
to repeat. There is no
it is a
need
full
to
dose, or
repeat
it is a rescue
corticosteroid.
single dose. It is a full dose, or it is a single rescue dose.
Single rescue dose.
Single rescue dose. So multiple administration of steroid can cause IUGR. So if it is given, it is not necessary. Again, it is a gray area. But if you choose, then it is only a single rescue dose. So this is important, and it is recommended irrespective of single or multiple group. But it is very, very gray area in the women with chorioamnitis, and recommended in IUGR and hypertensive disorder. And if patient is having GDM, admit patient so that you have the good control, because always the insulin or the pharmacological treatment has to be strengthened. So it seems that steroid dena bahut aasan hai, but now we have to be very careful and intricate, like when we want to give and when you have to cover with antibiotic if it is you are giving into the chorioamnitis. So tocolytic, already Amrita has put the thing. So Sumati, your choice. You said, I think Ritu ne kaha nifedipine, na? You nifedipine. And Maxerp is also a little bit tocolytic. Any Duodenone is isosuprene, Ditodrin, Atosiban.
We have been using Duodenone very much in our practice, but now it has been now nifedipine is the first drug of choice. But
nifedipine plain, yeah, nifedipine retard. Nifedipine plain, yeah, nifedipine retard. This is also
plain.
Yes. So important thing is that you give nifedipine plain if you are using it as a tocolytic and not as an
a stat dose of 20 to 30 milligram, then to be repeated after 4 hours. You can give 10 to 20 milligram for early till 48 hours only.
कोई भी Duodenone नहीं देता है, but
no role of maintenance tocolysis.
And how long? Even if
only for 24 to 48 hours. After that, there is no role of maintenance tocolysis.
Why? Any concern about it? It is important actually. Yes. क्यों हम नहीं देना चाहते 10 दिन 10 दिन?
This period is covered to steroids to take advantage of steroids.
Steroid हो गया, पर क्यों नहीं continue करते? हम तो चाहते हैं ना कि
because there is no benefit after giving it. I think so.
There is no benefit. There can be adverse effect. Chitra, you want to add to it? Why we don't want to give long-term tocolytic?
Because tocolytics they are effective only for 48 hours. They can prolong the gestation. They can calm the uterus for 7 or more days, but it is effective for 48 hours. So we don't usually continue it after 45 days. And when the contraction subsides, we usually discharge the patient.
Actually, important thing is that if you give the long-term tocolytic, it has a harm actually.
Side
It
effects.
may have it can have the fetal
Yes, ma'am.
electrolyte imbalance. It can have the like if you are giving steroid, a little bit infection, then the patient can go into the pulmonary edema. It can have tachycardia, palpitation, hypotension. So long-term use of tocolytic is harmful. And there is no reason. So we want to have that coverage of steroid, and most important, even more than steroid, that we want to shift the patient to the facility where the newborn care is there. So that is important. So no Duodnon or no nifedipine even for the first trimester or 1 month, because we see from corporate hospital, from Delhi, Bombay hospital, that they are having on the Duodnon and patient comes with a palpitation or cardiovascular problems are there. So it is very important that we restrict the tocolytic use only for 2 to 3 days. And isoflurane is not that bad drug also. For 48 hours, it's okay. It's not that bad drug also, so that we have to throw into the dustbin. Maxelf is also a tocolytic. Anybody who is using atoxicon, like abdominal circulation, we are fond of costly drugs. Big doctors use costly drugs. So anybody who have used and how far you have found effective or not? No, but everybody is saying. So we have less because it is very actually मैंने use किया एक दो बार, but I have not find any like anything added on, and it is so much invasive. You have to give loading dose and the continuous. I have not found. I have used it definitely before we put a question mark or accept or reject. We have to use the drug. That is important. That makes you confident that it is not working. So it is not recommended tocolytic. It is only for the short course. And magnesium sulfate, what Amrita has said, that from 24 to 32 week actually, not that Maxelf is a neuroprotector, and it is a now the strong recommendation. And the antibiotic Madhu आप करते हैं, intact membranes हैं, एंटीबायोटिक मधु आप देते हैं कि नहीं? ये जो पेशेंट है, ये रोज हम लोगों के यहाँ दिन रात आते रहते हैं ना, ऑलवेज पीपल कमर दर्द हो रहा है. So
I would prefer giving. I would prefer giving because any subclinical infection will also be a cause for preterm labor itself. So I would prefer giving.
Thank you for doing this.
Ma'am, with intact membranes, only if there is chorioamnionitis or showing features
I talked about subclinical. I talked about subclinical infection because, like, sometimes
infections, patient may not have symptoms, but there may be subclinical infection. In fact, the subclinical infections, they are more common than compared to.
And what is your drug of choice, Rita and Madhu? Right, fair enough. Because of course, vaginal swab we look for the this thing, an intact membrane, sometime antibiotic, but make a safe choice, and it is always at the backdrop of our thing that she might be having. So, what is your drug of choice, Madhu and
ampicillin and erythromycin? I prefer these two. Ampicillin,
but at the same time, we send the urine culture sensitivity, na ma'am. So
yes, genital urinary infection, that is.
Rita will be sending the urine culture.
Apple and Oracle trial actually warned that unindicated use of antibiotic can cause a problem. And MP Gentametrozole, when there is a frank leaking patient, we will like have 15 minutes to it. And amoxicillin chlorogenic acid is not recommended because again it has been proven that it causes neonatal enterocolitis. So pediatrician, it is isoparna. So pediatrician is the thing. Erythromycin, again the Western world says a lot about erythromycin, but like our people, like they don't like even upper respiratory tract infection, it is not treated by. So now the patient is relieved in pain. Aapne sab kuch kar diya. You want to give the patient on progesterone. Tocolytic we have covered. So Geeta, you want to put this patient on the progesterone so that she can continue up to 30 minutes.
I will put her in the progesterone. Hydroxyprogesterone caproate. Hydroxyprogesterone caproate, 250 milligram IM weekly till 36 weeks.
Or vaginal progesterone for anyone? One is the choice in terms.
We can put her on vaginal progesterone 200 milligram daily.
So it is not a 600, 800 milligram. One thing is important, that it is not a 600, 800 milligram, it is 200 milligram.
Yes, ma'am,
Yes,
200.
or 90 milligram progesterone, and whatever the patient is like. Actually, a little bit cautious, though the 17 OHP is the MFM, it is FDA approved drug for the prevention of preterm labor. But we again have some paper who says it is related to some childhood malignancy. So till now, vaginal progesterone is like like cheap also. We can be used easily also. Yet
but
the more
patients
drug
are
has
not
been
usually get ready to use vaginal progesterone.
then it's fine. Yes, it's fine. So coming to this patient, I think this will be the most important, the last patient before a quick comment on twin pregnancy. So it is 30-week gestation with frank leak. We will say it is frank leak. So Amrita, you put the question to us on. Amrita?
So ma'am,
Yes, ma'am. Yes, ma'am.
This
This question is to Dr. Rita Singh. She is the primary gravida, 30 weeks of gestation. She comes with discharge, and on PV and PS, we confirm the amniotic fluid leak. Or how are we going to confirm the amniotic fluid leak? Question to you, Dr. Rita Singh.
Patient is giving history of leaking. So we will confirm it by the per speculum examination. Mostly we can see the pool of amniotic fluid on the posterior fornix. And if there is no, we can ask the patient to cough, and we can see the amniotic fluid coming through the os.
Great.
So by that
Very
we can
nice,
confirm the leaking. And we should avoid the digital examination once we confirm the rupture of membrane. And again, the discussion is there. We should take the culture sensitivity from high vaginal vessel sensitivity.
It's fine. Yes,
Okay,
yes,
and
yes.
she's 30 weeks. We should give steroid. We should give antibiotic, and then again magnesium sulfate coverage we should give to this patient. And antibiotic of choice, ma'am, MP Genta for this patient.
So one very, very good message is by Rita. One is no pee per vaginal examination and ask the patient to cough. So you can see it. Fetal fibronectin पे उर्वशी ने भी बहुत बात की. 1 or 2 points I will like to give, that fetal fibronectin test is failed as a screening test. So if the patient has history of preterm labor, ये नहीं है कि आप routine में preterm like you do the fibronectin test. अगर in situation में जहाँ पे आपको लगता है ये patient अगले 7 दिन में labor में जाने वाली है, even in that fibronectin, it is negative test is more predictive than positive. Second important point. Thirdly, very, very important, that almost none is doing fibronectin. We are like discussing so long, but actually it is not available. Again, आपको जब 48 घंटे बाद report मिलेगी तो listen to fetal heart. What is rate? Maternal pulse and fetal heart rate, touch whether the patient is having febrile, and then per speculum examination. And you can do this litmus paper test, though you can really see. So actually, what we want to communicate, that very costly and hi-fi tests, even Western world is not doing. Actually, this sense of our self-esteem that they do and we don't do. Actually, we are doing, I think, much better thing, and which are more like proven method, and we can like quietly believe on our clinical acumenship in this situation. So that is the give confidence to every OB-GYN that they can handle it. And ultrasound, you will like to do, Rita?
Yes,
on this
ma'am.
patient? Yes,
Yes,
ma'am.
it is very important after to evaluate the fetal well-being, to rule out a placental position, the remaining amount
And the amount
liquor.
of liquor, it is very important to know the amount of liquor actually.
Yes.
So because it adds to your diagnosis, अगर liquor भी कम है तो definitely patient is having, and she is having the clinical symptoms. So amount of liquor, and one thing is they also look for the fetal like amniotic fluid sludge. If it is a sludge, actually it is indicative of chorioamnitis. So again, as a OB-GYN ultrasonologist से तो मतलब we have a different eye to look into ultrasound images, because we have to deal with the neonate and we have to deal. So this is very important. AFI gestational age is very, very important, because from if it is 34, you want to induce early, but it is 32, then you want to have a conservative treatment. So this is very important. So Garima, now this patient अल्ट्रासाउंड इसका हुआ 30 वीक 1.7 kg FI 9 अम्बिलिकल डॉपलर नॉर्मल. सो गरिमा यू व्हाट यू वांट टू डू? आप इसको फॉलो अप में रखेंगे, इंड्यूस करेंगे, हॉस्पिटल में रखेंगे कि घर भेजेंगे? गरिमा
हॉस्पिटल.
हाँ हॉस्पिटल. अच्छा वेरी नाइस. अब हॉस्पिटल में रख के क्या करेंगे हम उसका?
Ma'am, I will observe her for another 48 to 72 hours whether she'll go into labor or not. And when she doesn't go into labor and the steroid coverage has been done and CTG should be reassuring also, there should be no signs of chorioamnitis in this patient. Only then we can.
This is important. Actually, how you say this is important. Why we want to keep her in hospital? Because we want to have a check that patient is not going into the chorioamnitis. अब वही हम how आप nurses को या अपने resident doctor को क्या instruction देंगे? इस patient का ये चीज देखना है आपको सुबह शाम. So that is the point actually.
Pulse rate and temperature.
Pulse rate
and temperature. Very nice.
And tenderness.
CBC and CRP.
Fetal heart rate. Fetal heart rate more than 160 is indicative of impending chorioamnionitis actually.
Quality of discharge.
Rate, temperature and C-reactive protein. Yes, ma'am. We can.
CBC is.
And also for the uterine tenderness and the color of the discharge.
Great.
So how smell of the discharge?
So great. That is because actually this is the thing why we want to have the fetal improved outcome. So we want to like extend the gestational age at the time what happens, but we don't want a sepsis like a neonatal sepsis in postoperative as well as the maternal sepsis. That also creeps very very silently. So it is just what is the isolated maternal fever, the suspected triple I and the confirmed triple I. This is so suspected triple I is the baseline fetal tachycardia more than 160, maternal WBC count more than 15,000, and what Ritu has says the definite purulent fluid, and confirmed when you have the culture report with the placental pathology. So this is all the panelists have given such a wonderful message. But our nurses should be trained. Like जब हम लोग रेजिडेंट थे अभी हम लोग बहुत सीनियर हो गए. ऑल हर पेशेंट के बेड पे वो चार्ट होता था टेम्परेचर का ऊपर नीचे जाता हुआ. मुझे नहीं मालूम कि अब आजकल सिस्टर्स इतना धीरज रखती हैं. वो इलेक्ट्रॉनिक थर्मामीटर्स है. वी आर रियली मिसिंग द गुड टेम्परेचर रिकॉर्डिंग. दैट इज इम्पॉर्टेंट. पल्स रेट रिकॉर्डिंग विच वॉज very like a common in old nursing days, and of course the uterine tenderness and the fetal heart. So what we want to say that it's not the investigation. Actually, it is a temperature, maternal and fetal tachycardia and tenderness, which actually tells you much earlier that patient is going into chorioamnitis. So keep the patient जब तक कि मदर को फीवर नहीं आ रहा है, fetal movement भी अच्छा है, fetal bradycardia like fetal heart rate normal है, you can keep and you can go on for the 7 days or the 10 days, and that really adds to it. So leukocytosis, any comment about it, Ritu or Rita? आपका बेसलाइन है अभी 15,000 है या 12,000 है, तो कुछ फिजियोलॉजिकल भी ल्यूकोसाइटोसिस होती है.
You have to give antibiotics.
Yes, antibiotic is the very important, and steroid you want to give, na?
Yes, steroid.
So antibiotic यही. तो सुमति what antibiotic you give? अभी हमने एजिथ्रोमाइसिन की बात की, ampicillin, gentamicin, but now this patient is having 101 degree temperature and the reduced fetal movement. So she is in the frank chorioamnitis. So what you want to give? Escalate antibiotic, Sumati, what you want to give?
We can switch over to cephalosporin plus Genta plus Metrogyl.
And gentamicin.
So you have to escalate. If the patient is, आपने उसको पहले एक antibiotic दिया था, but despite that, if she is having the signs of chorioamnitis, you have to escalate. Second and the third generation cephalosporin are quite okay. Now, so this is important that in chorioamnitis, maternal antibiotic is very important to prevent maternal sepsis and the neonatal sepsis. Otherwise, हमारे pediatrician उससे जूझते ही रहेंगे. So this is very important. And when the patient is having chorioamnitis, always communicate. आप चाहे induce कर रहे हैं, deliver vaginally कर रहे हैं, cesarean, always communicate this to your pediatrician, neonatologist, that this patient is having this much of leak, so that they keep the babies on that line, antibiotic and the platelet count. If you don't communicate, sometimes you say हाँ बच्चा तो रो रहा था, it was fine, और suddenly बच्चा 12 या 24 घंटे बाद बहुत serious हो जाता है. So this is क्योंकि so many people say, अच्छा बच्चे को bedside कर दिया या कुछ भी किया, and patient baby suddenly died. So you have to communicate what was happening to this patient. You have given Maxel, the baby may be depressed. It was infective. So this is very, very important. Now it is choriamnitis. So antibiotic, I think we have covered second generation cephalosporin, and if it is a frank sepsis, then the piprotazobactam also can be given. And IV antibiotic for 24 hours when fever has subsided or till delivery, then oral antibiotic is given for 7 to 10 days. Because actually, patient can go into the postnatal puerperal sepsis also. Any comment on antipyretic? You want to give paracetamol or something like this? Yes. Anyone
Yes.
can.
Paracetamol is safest.
Paracetamol.
ऐसा तो नहीं कि आप सोचे उससे फिर पता नहीं पड़ेगा कि फीवर आ रहा है मदर को. Sometimes this is a question. This is a thing. No, it should be given because high, like temperature itself causes the fetal acidosis. So you have to give the symptomatic treatment. So this is very important, and we have to assess if the patient is having treatment. Steroid in setting of choriamnitis, you will like to give or you don't like to give?
No.
Can be given, ma'am.
No.
Can be given. So yes or no? So is the both.
No.
Geeta, bhi batao no kyun, Chitra?
No.
Can be given. Steroid may flare up the infection.
Ma'am, with
So
proper
actually, it is a
our
very
advantage.
Choriamnitis itself
advantage is-
accelerate the fetal lung maturity. So there is no need to give steroid in
And it
established
also flare
choriamnitis
up the
case.
infection.
It may flare up the infection.
And we have to hurry the delivery. In
Yes,
choriamnitis,
induction, we will
have to
come into
wait.
it. So now this is the thing. Actually, we are always in dilemma in the prom. So if it is a choriamnitis already setting, patient has come like that. आपने पहले नहीं दिया steroid, so it will really, क्योंकि वो leukocytosis भी बढ़ाएगा, it may flare up infection. And rightly says Geeta कि Rita ने कहा PPR, when there is a leak, there is an acceleration of fetal lung maturity. But even that, steroid might have more benefit to the preterm baby than the advantage, and we can give under antibiotic cover and the close observation. So again, it is like a gray area. But there are few papers which says that the administration of the corticosteroid actually reduces risk of neonatal complication, and it doesn't say that steroid actually increases the risk of choriamnitis or neonatal sepsis. Maxel we have already covered. You will like to give Maxel in these patients? Yes. 30 weeks. Yes, so it is yes. Tocolytic we will say no. एमनियो इन्फ्यूजन कोई कर रहा है कॉलेज में, एमनियो इन्फ्यूजन कभी बहुत सारे पेपर्स अचानक आने लगे थे, लीक है हम लोग एमनियो इन्फ्यूजन करें, नो, सो इट इज नॉट बीन प्रूवन. तो वही मैंने व्हाट आई वांट टू से वेस्टर्न वर्ल्ड बहुत कुछ करती रहती है बिकॉज वो प्रोटेक्टेड है आइदर इंश्योरेंस और द पब्लिक, बट वी हैव टू बी वेरी वेरी अलर्ट एंड इंटेलिजेंट. सो इट इज इन्वेजिव. So timing of delivery. So this is for the Rita and Chitra. You want to induce or you want to do cesarean? What you want to do for these?
Ma'am, we will induce only if she is developing signs of chorioamnionitis. Yes. Only then.
So you will induce or you cesarean kar denge Sita? What you do?
No, ma'am, induce. Cesarean has no advantage in this case.
Cesarean has no advantage. So we can at 30 to 30. If she is having choriamnitis, it is better. But actually, the prom is still, the evidence is not clear कि आपको कितने समय तक ले जाना है जब आप बच्चे को advantage दे सकते हैं. So after 35, 36 weeks, it's fine. It's better to induce after steroid cover. But between 24 to 34 weeks, it is a little bit gray areas, and up to you see any sign of maternal or fetal compromise, till then you should wait actually. So for these patients, it is better we do the 12-hourly CTG and every 3 days. If it is in hospital and every 3 days ultrasound, that it is not a very severe oligohydramnios or anhydramnios or any fetal compromise. So when you are, actually it is not a blind follow-up. It is a very, very alert follow-up because and you have to counsel that at this moment, when there is any maternal or fetal problem, we will deliver, we will terminate the treatment, either by induction. So that is very important, and very, very early prom, again, a lot of fetal issue can be there. And expectant कभी भी IVF pregnancies होती है, really we have to give the expectant treatment because of the patient or patient desire. हम लोग केवल evidence को नहीं कर सकते. आज के समय में we want to give message to everybody. Patient concern is also very, very important. So sometimes they are right also. क्योंकि अभी एक पेशेंट आईवीएफ की थी, लाइक दिस वाज oocyte डोनेशन, और वो 24 वीक पे एकदम फ्रैंक लीक के साथ आई विद द हाइपरटेंशन. तो वी गेव दिस for continue for at least 3 weeks 26 to 700 ग्राम बेबी, रूरल पेशेंट. लेकिन उसका बच्चा 3 महीने आईसीयू में रहा, 2 महीने मेडिकल कॉलेज के आईसीयू में, 1 महीने प्राइवेट में, बट बेबी इज फाइन. सो यू नेवर नो कि समटाइम पेशेंट इज आल्सो राइट. सो बेटर ऑलवेज गिव एंटीबायोटिक, बट you have to deliver whenever the things go wrong. Point to terminate any time when there is a non-reassuring fetal status, clinical or lab finding of chorioamnitis. Abruptio is also very important, and cesarean as a obstetrical indication. So coming to last question, the twin pregnancy with leak. Anybody, Sumiti, Ritu, Garima, any change in treatment?
Water discharge. 30 week.
नहीं, 30 week twin pregnancy, it is the same line of treatment what is in the singleton जो अभी हमने डिस्कस किया, या कुछ डिफरेंट होता है? नहीं. Yes, Sumati, no, she says no.
No.
Garima, anything, any change?
No change.
No change. So this is important. One message just I want to give, that yes, we don't want cervical circlage, but progesterone might be effective. But in twin pregnancy, it is better because twin have a different route for the preterm labor. So it is better that in all twin pregnancy, in 30 to 32 weeks, she comes to your antenatal checkup, give steroid, because they really have the prone to go into preterm labor. So before they go to preterm labor, actually babies have that advantage, and otherwise the treatment remains the same, and no circulation. And so thank you very much. We took a very, very simple day-to-day situation, but it brought out a lot of gray areas, and these are the all common situations. So never stop learning, because life never stop teaching. Thank you all the panel. Thank you, Madam Dr. Manju Verma, for being
Thank you,
with us.
thank you,
Yes,
thank you,
so
and
much.
thank you everyone. I really enjoyed the panel, and really congrats to you and Amrita and all the panelists. They have really answered very nicely.
Thank you, ma'am.
And the message has been cleared very, very clearly.
And I seek your full-hearted support for my candidature.
Oh, that's always there, and I am there, and we are there. We are there, rather.
Thank you, madam.
Bye.
Thank you. So
can I leave?
Yes, madam. Bas vote of thanks, Bacham. Yes, thank you, madam, for staying with us. Thank you very much.
So, coming to our official vote of thanks, I would like to thank our chief guest and guest of honor, Professor Gangadhar Sau. He gave a wonderful message that being spiritual is more important, and contribute whatever little you can, but contribution is important. And of course, Professor Usha Sharma ma'am, who is always very nice with her blessings and very smiling face and good nature. And of course, Manju Verma ma'am, who stayed till the very end. She not only gave her blessings, but she also gave her inputs during chairperson and also during our panel. My thanks to our speaker, Dr. Urvashi Burman Singh. She gave a complete package of information on preterm labor, be it reduction or management. Our panel was, and our chairpersons, Dr. Ranjana Khanna, Dr. Rajesh Gupta was not present, I think. Thanks to them also for conducting the session so smoothly. Coming to a panel discussion, it was brainstorming with so many wonderful cases and very crisp messages regarding the management, the tocolytic, the antibiotic, steroid, Maxal. So we all have clear whether it's use of progesterone and cerclage in twin pregnancies. So we all got very clear messages. So thanks to our moderator, Dr. Sadhana Gupta ma'am and Dr. Amrita Jaipuriar. Not to forget our panelists who are really, really well prepared for this session. Dr. Madhubala Sharma, Dr. Geeta Gupta, Dr. Rita Singh, Dr. Chitra Pandey, Dr. Garima Trivedi, Dr. Ritu Sinha, and Dr. Sumati Saxena. My sincerest thanks to my co-convener, Dr. Aruna Chaparia, and also my thanks to the IIT team, without whose support this webinar would not have run so very smoothly. So thank you, everyone. And of course,
Thank you,
not to
ma'am.
forget,
Thanks to you.
Sadhana ma'am is the most deserving presidential candidate of the year 2023. So wherever you are, please consult, please ask your friends, friends, anyone you know to kindly vote.